well, we'll get started then. So we'll talk a little bit about blood supply to the brain, a bit on the spinal cord. The last thing that we're going to have is on Monday, where we'll go over some of the functional areas of the cortex. We touched on those a bit last semester when we talked actually about this, when we talked about stroke. So for a review on that, go back to lecture 5 from MedPad 2. Those notes still apply. Today is not about how blood supply goes wrong, it's just about how it works normally. So the first part is going to be about our arterial supply, the major branches anyway. The second part is the low resistance drainage that we have via the veins and sinuses, and then how we regulate blood supply. Because it's fairly important. The brain gets a whole lot of blood. Every minute, there'll be about 50 mils or so of blood that hits every 100 grams of tissue. It's fairly well perfused. And that's because neurons are so energetically demanding. They're always moving ions. If they fail to move ions, they die. And what allows them to constantly move ions is the maintenance of those ionic imbalances that we touched on in lecture 3, 4, and all the others in between, I think. Maybe 2, I don't know. 2 is on development, I don't know.
Is your mic on?
I hit it there. It is. Yeah, thanks. Yeah. Yeah, it is, Daniel. And then the last part, just a very brief overview of the blood-brain barrier. I guess it's a gift and a curse. It's mostly a gift. This is going to restrict what enters the central nervous system from our blood. And this is a problem whenever you're developing drugs aimed at treating disorders of the nervous system, because most of them aren't going to get across the blood-brain barrier. That's the big hurdle. There's a couple ways to get in. You could be really, really small. You could be hydrophobic, or you can have a specific transporter. That's about it. But the first part's all about our vascular supply, and we can see it here. Here's a cerebral angiogram. So with this, you inject some radio-opaque, usually iodine-rich substance into the blood. It circulates around, and when you do a CT, you can see the blood vessels. Here they are. Here it is in a nice horizontal, coronal image. And we can reconstruct these in 3 dimensions right here. So we can see our vertebral arteries coming up, converging to form the vascular artery, and then it branches to form our posterior cerebral arteries. You can see this little tip aneurysm right there. Unfortunately, branch points are often weak spots where you get aneurysms. But that's not what today's about. We're going to start off by talking about the arterial blood supply, the source of glucose and oxygen. It's how we pay the bills. There's a couple of paired inputs. There's the internal carotid and your vertebral arteries. These are going to serve the forebrain and hindbrain, respectively. So it all comes from the aorta. So one of the first structures to be supplied from the heart is going to be the brain. And this is because the brain is so greedy. It needs to have good access to freshly oxygenated blood because it uses so much ATP. And without oxygen, we can't fuel our electron transport chain. We have nothing to accept electrons. We don't make as much ATP. And if you don't make as much ATP, you don't continue to live. When you're a supercharged cell like a neuron, something that's burning through an awful lot of ATP. So there's going to be a couple branch points off the aorta here. So we'll get our carotid here that's going to branch eventually to form the internal carotid. This is the one that we care about. That'll eventually perforate the skull. The subclavian artery is going to have a branch. The vertebral artery here is going to follow up along the vertebra and enter with the brainstem at the foramen magnum. There will be some branches on the ICA there to serve the face and the eyes. But eventually we're going to hit a structure called the circle of Willis right there. here's where we're going to meet up with our vertebral arteries after they converge and form the vascular artery. So the circle of Willis is where these two sources of blood are going to meet up. And it's called the circle of Willis because it's a circle. It's a circular structure here. And this is kind of nice because if you have occlusion anywhere along there, you have an alternate path. If I have a blockage right here, I can go around and still serve the other parts. So it's kind of a backup plan. And it's a way to have communication with both inputs, vertebral and internal carotid coming in here. There's going to be a few branches along the way. So the vertebral arteries are going to converge, form the vascular. There's a bunch of branches here that we'll get to in a bit. The branches that are going to help create the circle of Willis there are going to be the posterior cerebral arteries. The internal carotid is going to branch off and form the anterior cerebral artery, and it's going to continue along usually as the middle cerebral artery. Now, with all these branch points that I'm giving you, there is some wiggle room. People's vasculature can be a little different from one another. So here's the cartoon representation here for our circle of Willis. So we got our two sources of input, the internal carotid coming in here, vertebral coming in along the brainstem, forming the vascular, and then we branch, posterior cerebral. We got our posterior communicating artery that then links the posterior cerebral with our internal carotid here. The internal carotid is going to have some offshoots, but it's going to continue along as the middle cerebral artery, and it's going to branch form the anterior cerebral artery. We have another communicating artery here to link the two anterior cerebral arteries, and that's the anterior communicating artery. And there you have your circle. There's going to be some branches here to serve the hypothalamus, optic chiasm, optic tracts. So everything right around the circle of Willis is served by little offshoots from it that we don't see in the cartoon world that actually do exist. The three major offshoots we just went through, those different cerebral arteries, these are going to hit different areas of the forebrain, of the cerebrum. So they're going to have superficial and deep branches, all three of these. The middle cerebral artery is going to provide the major input for all hemispheres in the lateral portions of them. So that one's colored yellow up there. So we're going to hit the frontal, parietal, occipital, and temporal lobes, but more on the side. The more extreme areas, so the most superior, inferior, and medial portions are going to be served by the anterior and posterior cerebral arteries. And their name makes sense. The anterior cerebral artery is going to serve more anterior structures, frontal lobes, parietal lobes. The posterior cerebral artery is going to hit the occipital and temporal lobes. But they're not hitting the more lateral portions. They're hitting a lot more the medial and top and bottom there. Each of these is going to have deep perforating arteries that are going to serve the deep nuclei, the basal ganglia, the thalamus. So the basal ganglia are going to be served by the anterior and middle cerebral arteries. So here we can see the caudate right over here. That's going to be served by the deep branches of the anterior cerebral artery. And that's right on the way to hitting the medial portions of the frontal lobes here. Again, the lateral portions of the frontal lobes are going to be hit by the middle cerebral artery. And that is also going to hit the rest of the basal ganglia, so the putamen and the pallidum. This will also hit our internal capsule as well, because the internal capsule is going to kind of wrap between the thalamus and the basal ganglia, and then the caudate putamen. The posterior cerebral artery is going to hit the thalamus here. It's also going to serve the midbrain as well. So part of the hindbrain circulation is going to be served by the posterior cerebral artery. But for the most part, we're talking about offshoots from the basilar artery. So we're going to work our way up from the vertebral artery here. There's one offshoot that's going to hit the cerebellum here, the posterior inferior cerebellar arteries. So these are going to hit the majority of the bottom, the most inferior portion of the cerebellum, and then the posterior portions of it. We have our spinal arteries that come off of the vertebral arteries usually. The anterior will reliably, but the posterior spinal artery is most commonly actually going to come off the picot here, posterior inferior cerebellar artery. But not always. There's a little bit of wiggle room there. These are going to serve the medulla and spinal cord. Moving on up, once we form the basilar artery here, we're going to have a couple other offshoots. We're going to serve the cerebellum and inferior pons with our anterior inferior cerebellar arteries. So this will hit the bottom, inferior, but the more frontal portions. This is also going to serve the bottom of the pons. The majority of the pons is going to hit by the pontine arteries, as the name suggests. So these are going to perforate into the pons. The superior cerebellar arteries are going to hit the topmost portion of the cerebellum, so the superior portion of that, as well as the midbrain. So we got a couple branches that are serving the midbrain. We got a few that are serving the cerebellum. We got a couple that are serving the pons. And we got a couple that are serving the medulla. Anterior and posterior serving the anterior and posterior regions of the medulla. They will continue downward into the spinal cord, where we'll get some additional input. So not just the vertebral offshoots here. We're going to have other peripheral input along the spinal cord. But the anterior and posterior portions are going to run down, communicate with one another, and serve the anterior and posterior portions of the spinal cord, just like their name suggests. So the posterior columns are going to be served by those paired posterior spinal arteries, and that single anterior spinal artery is going to have offshoots that serve the rest of the spinal cord, so more motor and anterior lateral pathways. So those are your major branches from top to bottom. The names do make quite a bit of sense. Do we have any questions? Okay, then let's go through these. So that was our input. Obviously there has to be some output. And we want to have very low resistance drainage here, so that we don't have any spikes in pressure. We should remember from last semester that increases in intracranial pressure can be dangerous. So to avoid that, we have these massive sinuses that blood can drain into. We also have veins with no valves, so there's very little resistance. As the blood comes in, it can easily drain out, so we avoid any spikes in pressure. We can also avoid spikes in pressure by regulating blood flow. We've covered this a bit. We'll quickly touch on the barrel reflex, and then we'll add local regulation. Because different parts of the brain are going to be active to different degrees depending on the task that we're involved with. If it's a more visually demanding task, we need a little more blood back here. And we can adjust where we send the blood in the brain. We don't have to bathe it uniformly with blood. We can open up blood vessels in one region that's more active so that it gets the increased oxygen and glucose that it needs. Areas that are less active don't need that increase. So we can distribute the blood locally. This is the basis of fMRI, functional magnetic resonance imaging. The way that we look at brain activity using MRI is just by looking at a change in blood flow. Because if an area is more active, it's going to get more blood. We'll see how that happens at the end of this point. Okay, so the veins that drain our cerebrum are going to lack these valves. We will have bidirectional flow as a result. This can be a problem as metastatic cells that break off can move through these valveless veins. This is why you'll see metastasis in the spinal cord. There's no resistance. There's no valve that restricts flow in a single direction. But this is necessary because we want to avoid any spikes in pressure. So this, not true. Get rid of that valve. for the cerebrum. These valveless veins are going to drain into a number of sinuses. And these are just separations between the two layers of the dura. So these are big open areas, no musculature, no valves, nothing like that. Just a big, low resistance dump for the used blood. This is going to drain eventually to the internal jugular, and there we've completed our loop. We'll start off with the veins. These are going to drain into the nearest sinus. Veins. I said arteries. Didn't. Thought I made a mistake. Turns out not true. So the superficial arteries, those at the top, are going to drain into the superficial sagittal sinus there. Those that are more inferior are going to drain into the transverse sinus. We'll get into our sinuses in a bit. Nothing tricky here. The sinus that you're closest to, you drain into. So we have superficial veins. We also have some deep veins. Superficial veins are going to drain the more lateral portions of the cerebrum. We also have a middle vein that's connected by these anastomotic veins. There's superior and inferior, so we can hit the superior sagittal sinus or the transverse sinuses. We'll get to those in a bit. The deep veins are going to drain our basal nuclei, the medial structures of the cerebrum as well. These are all going to converge into the great cerebral vein that then eventually forms the straight sinus, and now we're into a sinus. Those deep veins are going to serve our basal ganglia and the thalamus. And that's basically it for the veins. They're fairly straightforward. Not a lot going on, just low resistance drainage to get us into an even lower resistance sinus. We got a few sinuses here. The superior sagittal sinus is on the top between the two cerebral hemispheres. So where that dura peels away to form the falx cerebri that lies between our two cerebellar hemispheres, right on top there, that open space is the superior sagittal sinus. This is going to drain back into the confluence of sinuses. That's where we're going to end up here for all of these. The inferior sagittal sinus runs in the more medial aspect. This is going to meet up with the straight sinus, so it'll converge with that great cerebral vein there, form the straight sinus, and then we're back at the confluence of sinuses. The occipital sinus is going to run down between our cerebellar hemispheres here. That's also going to meet at the confluence of sinuses. Going then around, here we have two transverse sinuses. So the cerebellum is sitting right here. So running around the sides of our forebrain between occipital lobe and cerebellum, we have the transverse sinuses. These are going to run around, form this little curvy sinus called the sigmoid sinus. So the name makes sense. It's kind of S-shaped. And then we're at our internal jugular. And we're done. Now we can drain on out, and we've completed the circuit here. There's an ultimate path there that we could take from the transverse sinus. We could also take the superior petrosal sinus and hit into the cavernous sinus. Now this is a major drainage site for those middle cerebral veins. And we got a few things running through our cavernous sinus. So it's not just a simple garbage dump for used blood. We have nerve fibers and the carotid arteries running through there. So there's a little bit going on. The cavernous sinus is going to kind of sit around our pituitary gland. We're going to be draining to the internal jugular via the petrosal sinuses. So there's the inferior that heads right on down. Again, you can have bidirectional flow here, so we could take the superior sigmoid and then get to the internal jugular. But all these sinuses are eventually going to drain via the internal jugular here. And there's a few routes that one can take. But regardless of where you start, you're going to end up in the confluence of sinuses, head on over to this transverse sinus, sigmoid, internal jugular. It's a fairly straightforward path there. The cavernous sinus has a few other things going in it. So we got the internal carotid there, and then we have cranial nerves 3 through 6, or at least the first two branches of cranial nerve 5 anyway. So upper face for that. not the mandibular branch. That's not running through here. But cranial nerves 3, 4, and 6, those control the eyes, those are running through here. So infection of the sinuses or the mouth, these can spread into the cavernous sinus here. You can see our two cavernous sinuses. There's your pituitary. And when we have infection here, that of course increases pressure, pushes on blood vessels, pushes on nerves. Alternatively, because we have these bony structures here, sometimes you'll get a breakage of these blood vessels running through there. That can also damage the nerve fibers running through. And that's what happens in this case. So there's an aneurysm in the cavernous sinus here. This is an 89-year-old woman. So 2 years before this, she had a fall. And that fall is what caused it. So she, let's see here, fractured her arm, and that was bad. But then she also had this swelling here in the right eye and throbbing headaches as a result. Because you have cranial nerve 5 running through there. The trigeminal is going to give you your headaches. Now what you'll notice is that she can't really open this eye as much. Cranial nerve 3. What they had to do is pull it open, and it might be hard for you to tell on here, but you should be able to tell in that picture, the blown pupil. So parasympathetic input is lost. Because running in that cavernous sinus there, you have cranial nerve 3. And that is going to provide our parasympathetic input to the eye. It's also going to help us open the eyelid. It's going to control almost all the muscles. We also have 4 and 6 running in there. And so what you end up with is an eye that you can't open, can't move, and has a constantly dilated pupil compared to the other. This eye still constricts in response to light. You can see it's a little smaller here than up here. So if they shine the light, this one constricts normally, not much going on over there. They tried to correct the aneurysm, couldn't do it. She declined surgery, so they gave her some gabapentin to control the headaches. Her eye, of course, couldn't be used after that, and then she lost sensation in the kind of upper region of her right face. And that's because of all the cranial nerves running through there. So it is a major site of drainage, but we have a little more stuff running through there. So we have this low resistance drainage so that we can quickly get stuff out. We don't want to build up pressure. Another way you can prevent the buildup of pressure is by properly regulating the input. And that's what we do with our barrel reflex. No need to review this. Again, if we have any changes in blood pressure, we can sense that on the internal carotid with our glosopharyngeal nerve there. That's going to stimulate parasympathetic output to decrease pressure. We can also adjust the global level of cerebral perfusion based on pH in the cerebrospinal fluid, because the smooth muscle in the vasculature there are responsive to changes in pH. And that's what we're looking at here. So these are in isolated smooth muscle cells. And what they did was adjust the pH by applying a little ammonium chloride. And here they're measuring the internal pH after they've applied it. You'll notice it increases. When you increase internal pH with this ammonium chloride, you also get an increase in intracellular calcium. So that's going to cause, of course, constriction of the blood vessel. When we have deficient blood supply, carbon dioxide builds up and pH drops. So it would be the opposite of this. Rather than getting an increase in calcium, you get a decrease in intracellular calcium, relaxation, and an increase in blood flow globally. So if you have any gross change in blood supply to the head, this can be sensed. And you can have a global increase. We can also have local regulation via the same mechanism, because active neurons are, of course, going to be using up oxygen, creating carbon dioxide. They're also going to be spitting out potassium. That potassium can also regulate the excitability of smooth muscle. So in areas where we have a whole lot of activity, we have a whole lot of potassium outside as well. Now, it might seem a little bit surprising to you, but when you increase extracellular potassium, you hyperpolarize the smooth muscle. And that's the opposite of what you'd expect. We'll get into why in just a second. So what they're looking at here, this is the diameter of smooth muscle, and they're stimulating the nearby nervous tissue. Control, they haven't added anything, it's just typical extracellular solution, electrical stim of the nervous tissue, and we can see this increase in diameter. We see vasodilation. That's blocked with barium, which blocks potassium channels. So this tells you that potassium channels are what's causing this. You can also block it with tetraethyl ammonium, same thing. The amount of vasodilation that we see, that's on the Y here, is decreased whenever we block potassium channels. So what's going to happen to the reversal of potassium whenever we increase its extracellular concentration? Is it going to depolarize or is it going to hyperpolarize? It's going to depolarize. Yeah, it's going to depolarize, right? Because we have high in, low out. As you build it up outside, you decrease that concentration difference, you decrease the amount of electrical force you need to offset that. So it won't be quite as negative. So why the hell are we hyperpolarizing? Well, we have potassium-sensitive potassium channels. Isn't that something? I know. We have a bunch of different potassium channels. It's a diverse family. Thanksgiving's fun at their house. When you increase extracellular potassium, sure, you're depolarizing the reversal, but what you're doing also is increasing permeability. So we can't just think about the Nernst equation, we got to think about the Goldman-Hodgkin-Katz equation. Permeability matters. When you increase permeability to potassium, do you move toward or away from its reversal? You move towards it, exactly. So sure, it's a little depolarized, but we're far more permeable to that potassium. So we move toward its slightly depolarized reversal, but it's still hyperpolarized to where the muscle cell is sitting. So yeah, we adjusted the reversal, but we changed the permeability, and that's the big driving factor here. Because we're more permeable to potassium, we hyperpolarize, and when we hyperpolarize, we relax. It's a little weird if you just think about the reversal potential. But when you take it to I think the next slide in that talk and look at the Goldman-Hodgkin-Katz equation, it makes sense. Permeability matters. Active neurons are also going to release nitric oxide. With high levels of activity, increases in intracellular calcium are going to stimulate neuronal nitric oxide synthase. When that's active, neurons are creating nitric oxide. It's freely diffusing. When it encounters smooth muscle, it's going to decrease their contraction. We're going to dephosphorylate myosin light chain. If it's not phosphorylated, myosin doesn't interact with actin. Without actin-myosin interactions, no contraction. So what we get is vasodilation as a result. So anything that enhances nitric oxide signaling or production is going to cause vasodilation. Any questions here? Okay, then let's go through these. So we send a lot of blood into the brain, but we want to be careful about what we pull out. Sometimes we have toxins floating through our blood. Sometimes it's by design. Some toxins are fun. Not all, though. We want to restrict what enters our central nervous system because there's no coming back from neuron loss. They're special and irreplaceable, just like all of you. So we want to restrict what comes in. Keep the toxic stuff in the blood. And let's be selective and cherry pick what we bring in to the safe place in our skull. The blood-brain barrier is going to protect this delicate nervous tissue. There's a couple points that create our blood-brain barrier. When you hear about it, you're usually hearing about the blood ECF barrier. So the barrier between the capillaries running in our cerebral tissue Their tight junctions are going to restrict entry from the blood into the parenchyma, into the extracellular fluid surrounding our nerve cells. But we also have vascular supply in the choroid plexus, so we can create CSF. So we have another blood-brain barrier there, that'd be the blood-CSF barrier. This isn't caused so much by tight junctions in the capillaries, because they don't have them. This is going to be caused by tight junctions between the ependymal cells, those glial cells that create CSF, so that everything over here floating around the CSF is kept clean and sacred, because we restrict entry from these sort of permeable capillaries via the ependymal cells. All the rest of the capillary beds that run through the entirety of our central nervous system, those are going to have tight junctions between their vascular epithelia, so they're a little different from other capillaries, and that's what's really going to be the restrictive component. So there's two parts of the blood-brain barrier that we need to be thinking about: the part that prevents entry and the part that allows entry. So the tight junctions are just these intercellular connections that restrict the diffusion of almost every water-soluble molecule. Only the smallest molecules are going to be able to find their way through. But those are very special cases. For the most part, if we're going to get in, we have to either be able to freely cross through membranes, so we have to be hydrophobic, we have to be non-polar, something like oxygen, for example. Can't hold it back. Oxygen is just going to move on through. Or we have to have a specific transporter protein that we can stick to, and that can transport us across our vascular epithelia. So here's our blood here. Here's the vascular epithelial cells. If they have a transporter protein to pick up whatever it is we're talking about, whether it's glucose, for example, glucose transporters are going to pull glucose out of the blood, move it through the epithelial cells, spit it out the other side. Astrocytes will pick it up and transport it to neurons, usually in an activity-dependent manner. But lining our blood vessels, we have astrocyte input processes. These kind of communicate back and forth. Astrocytes help maintain these tight junctions, but they are not the blood-brain barrier themselves. They help keep it together, and they're going to help transport molecules after they cross the blood-brain barrier. But they're just an additional step here afterward. They don't actually make the blood-brain barrier. They're just another layer of protection between blood and neurons somewhere down there. You don't want your neurons exposed to blood. When that happens, they die. We discussed that last semester. So you have to have specific transporter proteins. This is why designing drugs that target disorders of the nervous system is difficult, because most of them fail at that step. When you design drugs that are incredibly specific for the target that you care about, oftentimes you're going to find they don't have a transporter protein, so they don't make it across the blood-brain barrier. So this is an important initial step that we have to test whenever we're designing drugs for the central nervous system. You can have transporters that just remain there. You can also have surface proteins, like insulin receptors, for example, that are going to pull insulin into the central nervous system. So peptides will bind, the entire complex gets endocytosed and transported to the other side where insulin gets spat out, where it has a lower concentration. I suppose the most important to talk about would be, of course, oxygen and glucose. That's coming up, and that's what pays the bill, and that's what this whole lecture is about. Paying the bill. You need oxygen and glucose so we can maintain ionic balance. Oxygen just moves across freely. Glucose has transporters. Glucose transporters at the epithelia, glucose transporters in astrocytes, and glucose transporters in neurons. So there's going to be a few membranes we have to pass through before we get from blood to neuron. We got to pass through the epithelium. We got to pass into an astrocyte. That's going to transport it near the neuron, spit it out, and then neurons can take it up. So we go through 1, 2, 3, 4 membranes before we're actually sitting near the neuron to pick it up. That's basically your blood-brain barrier. If there's no transporter and you are water soluble, you're not likely to enter. Any questions? Yeah.
In the beginning, you said that some toxins are fun. to get in? Can you elaborate?
Ethanol. Ethanol is a toxin, and we use it as toxins. 70% ethanol is a great disinfectant. Doesn't taste as good. We usually dilute it a bit, maybe 40%. 7. Yeah, exactly. So it's a toxin. We put it in our blood, and then that one does make it in the brain.
Okay.
But there are others, you know, like viruses,
Those are fun.
bacteria. No.
Oh.
Those are the non-fun toxins.
Got it.
Because when they enter the central nervous system, bad things happen. Ethanol, sometimes bad things happen, and sometimes that's part of the fun. Alrighty. Let's go through the last checkpoint.